surgeryandmedicine.com, your med school in your pocket.
Welcome to the video podcast about anal fissure. This podcast is aimed mainly at medical students, although it may be useful for newly qualified doctors or surgical trainees taking their MRCS. What we're going to talk about today is fissure in ano, and more information is available at www.learncolorectalsurgery.com. Learn colorectal surgery, all one word. So what is a fissure? A fissure is a split in the anal canal. It's a common condition and causes a great deal of stress to those people who suffer from it. When the classical symptom is pain on defecation with a small amount of fresh rectal bleeding. The pain is quite severe, and patients often describe it as like passing broken glass. It's quite debilitating. It occurs in young to middle-aged adults and tends to keep them from social activities and also off work from time to time. It could be quite an uncomfortable thing to have. There are two kinds of fissure. Acute fissures, which come and go in a few days but can be quite sore, and the best treatment for these is to have plenty of fibre and fluid to pass a soft and bulky stool without straining, and these will settle down by themselves. The other kind of fissure is chronic anal fissure, and some of the acute fissures don't settle down by themselves, and patients can have persistent symptoms which wax and wane but are always there for weeks, months and sometimes even years. In a minute I'll explain how fissures are caused with the help of a diagram, and we'll talk about treatments at that time. Most fissures just occur by themselves with no other underlying cause, but there are some other diseases that can cause fissure. It can be present in Crohn's disease and also other less common diseases such as sarcoid, syphilis, TB and some other conditions. It's a not uncommon complication of pregnancy, and it's probably the second commonest complication in the postnatal period after hemorrhoids. Okay, so to understand anal fissure it's necessary to understand the anatomy of the anal canal. Firstly, what causes it in most cases. For many years it was thought that patients were constipated and passed a hard stool bolus which split the anal canal, which caused pain, which made them avoid going to the toilet. They got anal spasm and got more constipation, so a vicious cycle built up. However, when patients are asked if they had constipation at the start of symptoms, only about a quarter, so they did, and a lot of patients had diarrhoea. And there was obviously something else going on. Now, recently a theory about blood supply has been developed, and fissures may in fact be an ischemic ulcer, rather like ischemic ulcers that you can see on legs of vascular patients. But to understand why, I'll draw you a diagram. So this is the lumen of the anal canal in there, and crucially around this goes the internal anal sphincter in a complete muscular ring around the anus. Now, the blood supply to the anal canal comes in from the side, runs to the internal pudendal artery and gives off branches to the back and to the front from both sides. So there's branches on the outside of the sphincter, and then branches as it goes past the sphincter. And you can see that most people have a blood supply that is pretty complete anteriorly, but interestingly we've found from studies that there's a very poor blood supply in the posterior midline of the anal canal, and this is where most fissures occur. Certainly 98-99% in men and 90% or so in women. Now, obviously, a lot of people have a blood supply like this, but people with fissure also have quite a high tone in their internal anal sphincter. So the theory is that you have a poor anatomical blood supply here. The fissure, the internal sphincter contracts and just really makes that pretty ischemic area. So if you do pass a hard stool bolus, you get a little tear here. There's not enough blood supply to heal that tear, so it persists. Or even the blood supply becomes so bad that it just breaks down by itself, or there's a minimal trauma So you don't actually have to pass a very hard stool bolus to do this, but if you do, it may be difficult for the area to heal up. And so the fissure, not enough blood supply, develops here in the posterior midline in most people. So if that's an ischemic ulcer, what we can't do obviously is, as you would with an ischemic ulcer in the leg say, and do a bypass graft to improve the blood supply coming in. But what we can do is decrease the tone of the internal anal sphincter. This is what's been happening for 200 or 300 years with various operations. One of the first things people tried was, and which has been going on until relatively recently, and still done from time to time, is a forced anal dilatation or an anal stretch, where fingers are put inside the anus and the fingers pull apart like this and disrupt, is probably a tactful way of putting it, the internal anal sphincter. People have stopped doing this so much now, as of course this causes all kinds of damage to the internal and sometimes the external sphincter, and it has quite a negative effect on continence. A slightly more subtle approach is to divide part of the internal sphincter, something called an internal anal sphincterotomy, and this is a very good operation for curing fissures. And of course, it doesn't really matter if you have the fissure cured, the fissure gone or not. What people want is relief of pain. It's a very good and effective way of relieving pain. So the sphincter is divided. We know then that the sphincter tone goes down, more blood comes into the area which we can measure, and the fissures heal. About 95% of fissures will heal with an internal sphincterotomy. The most common reason for these fissure not healing is that during the operation it's been difficult to identify the internal sphincter, and a later ultrasound shows that the sphincter hasn't actually been divided. But again, this can cause problems. Obviously, divide part of the sphincter, then you do have an effect on continence. And studies show that maybe up to about 30% of people have some form of impaired continence. So this doesn't mean that they have frank fecal incontinence, but that fine tuning of continence is impaired, and so they can't hold onto gas quite as well, or can't hold onto liquid stool quite as well. So sphincterotomy is a very good operation, but can cause some impairment of continence. The next advancing treatment of anal fissure came when greater understanding of the physiology of the internal anal sphincter was reported, and like many smooth muscle cells, the major inhibitory neurotransmitter involved in the internal anal sphincter is nitric oxide. So if you give nitric oxide to smooth muscle cells in the lab, they will relax and give you what's known as a chemical sphincterotomy. So what we have to do then is to provide some nitric oxide. How can we do that? Well, nitrates are very good at doing this, and so the first treatment that was widely used to treat internal sphincter with a non-surgical means was glycerol trinitrate, or GTN, and as the name implies, there are 3 molecules here where nitric oxide can be released. You apply GTN, it relaxes the smooth muscle of the internal sphincter, improves blood supply, and heals fissure. Well, he's very good at treating the symptoms of the pain from the fissure, decreases relatively quickly, and actually heals the fissure, i.e. the fissure re-epithelializes in somewhere between half and 2/3 of patients. The downside of GTN is that, like many nitrates, it's absorbed systemically and can give people headaches, and so that stops people taking it. So the next thing that people developed was looking at how else we can relax smooth muscle, and another quite commonly used mechanism for relaxing smooth muscle is to block calcium influx, and so we use calcium channel blockers, and these block the influx of calcium and so cause the smooth muscle to relax, and again increase the blood supply into the posterior midline of the anal canal and heal the fissure, again somewhere between half and 2/3 of patients. These are much better tolerated, as there are much fewer side effects, and certainly don't give you the headache that GTN does. So, in summary, then, that's anal fissure. It's not an uncommon thing that affects young to middle-aged adults, causes pain on defecation and some anal canal bleeding. It can be treated successfully in operation, but you have to be aware of impairment and continence. And so most people now are encouraged to increase the fibre in their diet to pass a soft bulk, still without straining. So acute fissures will mostly settle down with this. Chronic fissures should have topical creams as a first line, either topical nitrates or calcium channel blockers, and this heals about half to 2/3 of patients, and those who don't heal should be sent to a colorectal surgeon, probably for an internal sphincterotomy. You have to be aware of people that have had previous obstetric trauma, and so be careful in women either who often have an occult sphincter injury after delivery of a child, or if they're considering childbirth in the future. You have to be careful with the integrity of their sphincters. There are various mechanisms for treating people with low pressure sphincters. If you're interested in this, there's a link to a paper if you go to www.learncolorectalsurgery.com. Other treatments that relax the resting tone in the internal sphincter are botulinum toxin, and there are other operations such as sphincterectomy, which are becoming more popular at the moment. Advancement flaps are also occasionally used. I think that's a bit beyond the scope of this podcast, and I say if you need more information than that, if you link to the site that I mentioned.